Good morning, everyone. I would like to thank the organizers for the invitation to speak about rapid start of art. I'm really disappointed to not give this talk in person. I was supposed to be in the meeting in person, but unfortunately couldn't make it due to COVID travel restrictions. Nevertheless, I hope you enjoy this talk. So first of all, I do not have any conflict of interest to declare in relation to this presentation. So our HIV programs have really matured over the last 20 years, and I think we've seen major strides made across the continent in ending the HIV epidemic. In the early days, and I remember working in Malawi, we used to start individuals at low CD4 counts and often with comorbidity. And gradually we saw this CD4 threshold increase, first to 350 cells, later to 500 cells. And in the end, about 5 years ago, most countries adopted the universal test and treat recommendation. And I think this change in guidelines, and in particular in art eligibility, have really had a dramatic impact on life expectancy and reducing morbidity and mortality in Africa. So the next step is, how do we push the agenda further towards ending the HIV epidemic? And I think it's important to look at some of the terminology in that context, especially if it comes to rapid art initiation. So we speak about universal test and treat in the context of art eligibility of people living with HIV. And it simply means that all individuals living with HIV can initiate or should initiate antiretroviral therapy, regardless of their CD4 count, but still guided by clinical presentation. In other words, we should make sure that people are clinically eligible to start art. Rapid art initiation, on the other hand, is much more about timing of art initiation and is largely driven by our health programs and not so much about our individuals' eligibility. So it means we should initiate art within 7 days of HIV diagnosis, providing individuals are eligible. And that speaks to my previous point. And if people are ready, they should start art on the same day as the HIV diagnosis, or when they return to a facility, for example, with a known HIV status and treatment history. And this is a recommendation that is endorsed by the World Health Organization and has been adopted by most countries as part of their HIV programs. Now, what changed with the introduction or with the rapid art initiation program? So the main changes compared to the previous standard of care are that there's no need for a CD4 count before art initiation, and actually that is a change that was related to the introduction of UTT and not so much the rapid art initiation program, but because these two changes occurred quite closely in time, they're often regarded as part of rapid art initiation. So no need for CD4 count before initiation, no longer need for 3 treatment counseling options before someone can start, and last, there's no need for a treatment supporter or to go through a disclosure process with partner or family or relatives before art initiation. What has remained the same? What has remained the same with rapid art initiation and with UTT is that we should still do a comprehensive clinical workup before people should start or be offered art. There should be ongoing counseling and treatment support. And I think it's important to realize that a lot of this was done pre-art in the past, and now with rapid art initiation, we continue with the same process, but with the big difference that people are now taking treatment and not waiting for treatment. And last, we would try and have a patient-centered approach as much as possible. That hasn't changed either. So what's the basis? Why do we do rapid ART initiation? And this strong recommendation comes from this very nice systematic review and meta-analysis of the data in 4 trials that were conducted, 3 of those on the African continent and 1 in Haiti. And what these 3 clinical trials showed is that if we do rapid ART initiation or same-day ART initiation, the outcomes are better than with the standard of care. Meaning that in these clinical trials, rapid ART initiation resulted in more people living with HIV starting ART, more people remaining on ART, so higher retention, and more people achieving viral suppression at 12 months post-treatment. So based on these results, better linkage to care, better retention, and better viral suppression, rapid ART initiation was widely recommended, and most countries have adopted this strategy as part of their HIV programs. The reality is actually not always as perfect, and I think some of the resistance to rapid ART initiation comes from some of the studies that show that it might not be as good in reality, or the performance might not be as good in reality as it is in the clinical trials. So this is an example of data from South Africa, where they did an analysis of routine program data that were collected in Tear.net. Antiretroviral is an electronic database that captures all treatment data for 6 high-burden districts in the country. And what this analysis showed is that in the blue line we have same-day ART initiation. The retention, so the probability of the likelihood of loss to follow-up, the retention is much lower in those initiating ART on the same day of diagnosis than in those initiating, for example, at 1 to 7 days, the red line, 8 to 21 days, the green line, and then the yellow line is more than 3 weeks. So in this analysis of routine program data, rapid ART initiation was associated with a lower retention in care. It doesn't necessarily mean that rapid ART initiation leads to fewer people on treatment, because a lot more people are initiated on the same day. In the end, there might be a net increase in the HIV program in the numbers on treatment. It's just more people that move in and out the program. A similar observation comes from a study done in Ethiopia, where they compared a same-day initiation group in the brown line with individuals initiating ART more than 7 days after the initial diagnosis. And again, we see a drop or a lower retention rate in those with same-day treatment compared to 7 days. And what's interesting, I think, to see, and it was the same in the South African data, that the loss in the same-day group is generally happening in the early stages, so in the first 1 to 3 months of ART, and after that, the trend line for retention are very similar between the early and the late groups. So the bottom line is, if we lose people in the early initiation group, it's usually early on, and our intervention should focus on increasing retention in the early phases after rapid ART initiation. The second thing they saw in this study was that viral suppression, in the table at the bottom, viral suppression at 12 months was not as good as in the same-day initiation group as the group that had been initiated more than 7 days after diagnosis. So in this study, both retention and viral suppression were lower in the same-day group than in the delayed group. Then a last example from 2 primary healthcare facilities in Johannesburg, where they tried to untangle the effects of changing a guideline, so the guideline change from pre-UTT to UTT, and subsequent guideline change from UTT to same-day initiation at the top. So the bars in blue are individuals that were retained in care at 12 months post-initiation. And what we see at the bottom is that in the pre-UTT group, retention was only just over 50%, which is rather low. These retention rates increased with the introduction of UTT to just over 60%. But in times of same-day initiation, that gain fell back again to low in the 50% in the same-day initiation era. So in these two facilities, the change to same-day initiation did not result in much higher retention compared to pre-UTT. What they did see, though, is a difference in those that are lost to follow-up. So in the past, pre-UTT, we saw a lot of people lost to follow-up before ART initiation, so that's the orange and grey bars. And in the same-day initiation era, not surprisingly, most of the loss to follow-up occurs in individuals on antiretroviral therapy, so the yellow and the green bars at the top. I think the main item with this slide is that overall, quite a large group in all three areas is actually lost to follow-up, and that highlights the issues with retention in care in our antiretroviral therapy programs. So we see an interesting difference between what is reported in clinical trials, and generally that's a well-controlled, well-implemented, well-resourced environment, and what we see in real life or in reality in some of the observational studies that have been published. And it means that not so much, I think, that we should say or wonder why or how rapid ART is feasible based on these observational studies. I think we should focus much more on how to make rapid ART feasible. So the results of clinical trials really show a clear benefit on patient outcomes, much better than we see in the observational studies. So how can we bridge this gap between the reality and the world or the data generated in clinical trials? And I think that talks to how do we optimize our program delivery and program implementation, because that's the main difference between clinical trials and our observational studies. How is this intervention delivered? And I think to optimize program implementation, I think there's three types of barriers and facilities we should consider. One is around clinical management, one is around patient-centered approaches, and the last one is around structural and programmatic drivers and policy environment. So if we start talking about clinical feasibility, I think one of the questions I often get is, are we not missing any clinical conditions that require workup before ART initiation? So clinicians are reluctant to start ART on the same day or within the first 7 days because they're worried that they miss important clinical conditions. There's a number of things I think to consider here. So first of all people living with ART are eligible for, with HIV eligible for ART initiation, regardless of CD4 count. And this criterion has got nothing to do with the rapid ART initiation program. It's part of our UTT, where there's a clear benefit of initiating ART in people living with HIV regardless of CD4 count. So it's really about the timing of ART initiation based on eligibility. And what I mean by that is that rapid ART is something that should be offered to patients once they are eligible. And it shouldn't be offered to everybody. It should only be offered if you are eligible and based on an eligibility screening. And this eligibility screening really requires a standard clinical workup. So we, before offering people same-day ART or before offering rapid ART initiation, we do a clinical workup where we look for TB symptoms and do a diagnostic TB symptom screening if required. We look for signs of meningitis, and we assess for other opportunistic infections that require treatment. And only when we are sure that someone is eligible, so there's no signs of meningitis and there's no signs of TB, is when we would consider someone eligible for same-day ART or rapid ART initiation. So that should take away some of the pressure, I think, that healthcare workers feel to initiate people living with HIV on ART. We know a lot of people work in a target-driven environment where there is high targets to initiate people on ART and to achieve a high coverage of same-day initiation. And I think one of the main things to consider in that context is our denominator, where the denominator for same-day initiation coverage should really be those that are eligible and not necessarily all with an HIV diagnosis. So only once someone is eligible, they should be counted towards same-day initiation targets. This also applies to those that need to delay ART initiation because of comorbidity. So if we delay ART initiation, for example, because someone is diagnosed with TB, they become eligible after a number of weeks on TB treatment. And once they become eligible, ART initiation should not be delayed. So again, it's about eligibility for rapid ART and same-day ART initiation, and not so much about initiating everybody with an HIV diagnosis on the same day. So one of the things that we're worried about is people are pressurized to initiate people on ART, and that we really miss some of these clinical diagnoses. But it doesn't really reflect in mortality data. So the START ART trial that was conducted in Uganda saw a 2% mortality in those initiating rapid ART, and a 3% mortality in the standard of care group at 12 months. So in the trial setting, there was no people slipping through the cracks as a result of same-day or rapid ART initiation. And the same in an observational study from Johannesburg. There was no evidence of increased mortality in the same-day initiation group. You can see in the table at the bottom here that the time to initiation following HIV diagnosis increases in time to initiation reflect or result in an increased mortality, where we had a 0.4% mortality if rapid ART was initiated. That slightly increased if people initiated between 1 and 3 weeks, and increased further if ART was delayed by 3 weeks or more. So certainly it doesn't seem that a lot of people are missed in the clinical workup and die as a result thereof. The effects of delaying ART on mortality are larger than those that might slip through. So how about ART initiation in low CD4 counts? It's another comment that we hear often. Where clinicians are concerned that people with a low CD4 count should really be comprehensively assessed and managed before they start ART. So I think in that context, it's really important to realize that mortality is the highest in the groups with the lowest CD4 count, and that is regardless of timing of ART. So in the table at the bottom, this study looked at the 1-year mortality and excess in mortality in relation to ART initiation. And I've highlighted the group on the left that started ART on the same day, and I've highlighted the 10 weeks group in the middle. And what we see is that if we look at the different CD4 strata, in those initiating ART on the same day, in the left table, the highest strata, so 300 to 350 in this analysis, 2.8% of people died. Whereas if you look at the bottom, In the less than 50 CD4 count group, it's 20% of people that die. And we see the same trend where we see an increasing mortality with lower CD4 count in the 10 weeks group as well. So the bottom line is people that start art, or people that start art, they do die, and the lower the CD4 counts, the higher the risk of mortality. And it has nothing to do with same-day initiation. It's simply because this group has a higher mortality rate because of low CD4 count, and not because of timing of art initiation. Then the highest impact of delays in art initiation are also in the group with the lowest CD4 count. So here I've highlighted the 300 to 350 cells group at the top and the less than 50 cells at the bottom. And what we see is that the longer you delay art initiation, the higher the mortality. So in the 300 to 350 group, 2.8% of people dies with same-day initiation. And that goes up to 5.1% if you initiate art only a year after diagnosis. But when we look at the less than 50 CD4 count group, this effect is much more dramatic. So 20% mortality in the group that initiates on the same day, which increases to almost 30% at 10 weeks post-diagnosis, and at a year post-diagnosis, almost 50% of people living with HIV and these low CD4 counts would have died. So we can't really afford to delay art in these groups with low CD4 counts. So rather than seeing it as a group that you're reluctant in to initiate art as soon as possible, it's actually the group that should be prioritized to initiate art as soon as possible. So how about the emergence of antiretroviral resistance? That's another concern we hear often. And I think there's not a lot of data out there. It really is driven, most of the data are driven by local pre-treatment data, and the impact of resistance is really related to the first-line regimen that is used in each setting. But there's not a lot of data about emergence associated with rapid art. There is an important observation, though, and it comes from a study in Lesotho where they conducted a follow-up of individuals that didn't link to care following home-based rapid art initiation. And what they saw when they contacted these individuals is that, in this case, quite a large number of them, although they were given art for same-day start, they never took any pills. So it means that same-day art initiation doesn't mean that people actually take pills. So the group that is lost to follow-up or lost to care after same-day initiation might not all take pills and expose virus to drug. And the second observation in this group is that they did see some NNRTI mutations. They used an efavirenz-based regimen at that time for rapid art initiation, but it's not clear whether these mutations are primary resistance related to transmission, or that they are acquired in response to rapid art. So the vote on this one is still out, I think. So how can we make rapid art more attractive to people living with HIV? And an important thing, I think, is to simply ask them, why don't you want to start, or what are barriers to you starting art on the same day or quite soon? And this was a very nice study done in Zambia, where they asked a number of people about reasons for not wanting to initiate same-day art. And I think if you look at the left, most of these reasons we hear in our clinics on a daily basis. I'm too busy, clinics are not private, I'm worried about my friends, my family, I'm not feeling sick. There's a lot of these aspects that we hear on a daily basis. And if you look at the type of reasons that people report for not initiating art, then these are either personal reasons, So the blue circle, the social reasons, and there might be structural reasons. But I think especially the presence of a lot of personal and social reasons emphasizes the importance of investing in counseling and psychosocial support services to strengthen our uptake of rapid art. There are important differences between different age groups and between men and women in reasons to not initiate art on the same day. And these are the data from the same study in Zambia at the bottom that show these differences between age groups. So, for example, fear of disclosure and perceptions of judgment is an important reason in the older groups. Whereas younger people generally are too busy or feel that the clinics are too crowded and see that as a main barrier. And I think it's important to know your population and to figure out what the barriers are in your specific facility to try and mitigate these and to improve same-day art initiation. So a lot of talk about good home-based initiation work. Is that an option to increase rapid art or same-day art initiation? So this is a study experience from Lesotho, where they did home-based art initiation by lay healthcare workers, followed by referral to the facility for further management at 30 days. And they saw a higher proportion of participants retained in care with same-day art than with the usual care. So linkage to care was better if initiated at home than it was when people were only initiated at facility following linkage. And the viral load at 1 year after enrollment. Performance was better in the same-day art group than in the usual care group, although the general suppression rate wasn't too high. So in this setting, same-day art provided at home followed by linkage to a facility performed better than linkage to a facility for art initiation. Now, why didn't some of these people link to care? So despite the higher retention and the higher viral load suppression, linkage wasn't optimal, both for those initiated on the same day and those that were referred for further care. And important priorities were too busy and refused to attend care. So what they thought then was, or what was then thought is, can we not make this a community-based program? So can we not limit the clinic visits as much as possible and really manage people in the community? So a FIBA trial was conducted also in Lesotho, where the standard of care was done, where people either offered home-based or facility-based art initiation, followed by a clinic visit for refills and management of 1 to 3 months. Compared to really a home-based model where people would be offered same-day art at home and further management at home by village health workers, and only a 6 and 12 months visited the facility for viral load. Now, what they saw in this study was actually a bit disappointing. The acceptability or the uptake of home-based rapid art was low. So only 41% of people actually opted for refill by the village health workers. So most people actually preferred to be linked to a facility instead of continuing to be managed at their homes. And when we look at these bars, especially the right to, we see in the green, we see those that were retained in care by suppression. And what you can see is that control bars, so those that were further managed at the facility, they were slightly higher, retention rates were slightly better than in the intervention rates, where voluntary healthcare workers continue to manage these individuals at home. And the second concerning observation is the small grey bar at the top of the 6 and 12 months bars, reflecting people who died in the program. And although not statistically significant, mortality was higher in the intervention group than in the control group. So the bottom line, I think, from this study is that we can task shift to community workers as much as we can, but there's also limits in task shifting, and it seems in this setting that some engagement with the clinical care system is really required for good outcomes. Now the last comment is, how do we improve program delivery? Can we improve delivery of our healthcare programs? And in that sense, I really would like to mention the efforts done in Botswana over the last couple of years in the PEPFAR program and the district support partners, where the government released a program of rebooting HIV services to achieve epidemic control. And this program had 4 elements. It focused on training facility healthcare workers and their peers for client-centered monitoring and ART initiation. They extended the clinic hours. They offered starter packs at different entry points with an option for people to transfer to a preferred facility. And they invested in coordinating ART linkage between facility and communities. And I think the latter component is really an important one to improve outcomes. So how does that look like geographically? So this is just a very simple schematic representation of what their program looked like. And I'm not going to go through it, but I think the main take-home message is that there's a comprehensive team in facility, so a clinician or a fast-track champion with a peer counsellor who works really closely with community health workers and other community structures to either initiate and to link people to care for initiation and follow-up. Now, the reboot strategy that the government implemented really delivered on its objective of improving rapid ART. So same-day initiations increased from 28% to 59% during reboot, and rapid ART, so within a week, increased from 56% to 78% during reboot. And these effects were the same for men and women and for all age groups. So this really shows that comprehensive effort and investment of government, Ministry of Health, implementing partners, and people on the ground, where community and facilities work together as a team, can really improve outcomes of our rapid ART program. So in conclusion, the concept of rapid ART initiation is really recommended and should be the standard of care across Africa. There's clear benefits for individuals as well as for public health programs shown in clinical trials that really make this an important intervention towards ending the HIV epidemic. And rather than challenging the current data from observational studies, I think we should focus on achieving the same results that we saw in these clinical trials in our real-world settings across Africa. And you will have seen that I've used examples from all across Africa to show the challenges but also the benefits of rapid ART initiation. So in my opinion, it's not a matter of if, but rather how to make rapid ART work in Africa. And I think there's a number of things that we should push. So first, I don't think there's any clinical barriers to rapid ART initiation. We should just do a comprehensive workup, and once people are eligible, we should initiate them on ART. I think healthcare workers and patients should not feel pressurized in the context of targets, and if possible, reconsider the denominator to measure same-day initiation coverage where it's about patients' eligibility and not so much about those diagnosed with HIV. Settings should consider personal, social, and structural factors for service improvement. We've seen that there's different responses and different needs in different settings. Differentiated care, models of care can work. We can actually conduct rapid ART initiation in communities, but task shifting really has its limit, and an interaction and engagement with healthcare facilities should continue. And last, strong support from a national government and funding agencies and implementing partners can really enhance program implementation and help achieve our goals. So thank you for your attention. Together we will end the HIV epidemic, and I'm happy to take any questions. Thank you very much.